Bismillah ar-Rahman ar-Rahim. Risk of malignancy index. An estimation of the risk of malignancy is essential in the assessment of an ovarian mass, and there are three methods to assess it. Simple module involve using discrete cutoff value, which are CA125 pulsatility index and resistance index. Intermediate modules that widely used, and they are two: morphology scoring system, and we use them in aorta, and the risk of malignancy index, the one that we will speak about today. And lastly, advanced modules includes artificial neural network and multiple logistic regression modules. At present, the risk of malignancy index, RMI, is the most widely used modules, but the ultrasound rule derived from the aorta has still increased sensitivities and specificities. The risk of malignancy index was first described by Jacob in 1990 and has since evolved into 4 generations: 1, 2, 3, and 4. But to date, only 1 and 2 have been sufficiently validated. Risk of malignancy index 1, this one is adopted and used by the Royal College of Obstetric and Gynae and include 3 pre-surgical features, and they are serum CA125, menopausal status, and ultrasound score. Collect them in an equations, and it includes risk of malignancy index 1 equal to ultrasound features multiplied by menopausal status and multiplied by CA125. The ultrasound features is scored 1 point for each of the following characters. It means that if there is no character, we will score 0. If there is one of them, we will give 1. And if there is 2 or more of them, we will give 3. Coming to the menopausal status, we will give 1 for premenopausal women, and we will give 3 for postmenopausal women. The classification of postmenopausal women, as all we know, is a woman who has had no period for more than 1 year, or a woman over 50 years who had had a hysterectomy. It means that if the woman was 45 years and has hysterectomy, we will not consider her as a postmenopausal status. We will give her still 1. Serum CA125 is measured in international units per ml and can vary between 0 and hundreds or even thousands of units. And all of us, we know the normal cutoff level. What are the drawbacks of this CA125? This marker is unreliable in differentiating benign from malignant ovarian mass where in premenopausal women because of 2 things. Number 1, the increased rate of false positive and reduced specificity, since we can find it increase in a multiple condition, benign conditions. 2, it is a marker for epithelial ovarian carcinoma. It means that it is specific, more specific for and sensitive for epithelial ovarian carcinoma. We will not find it increase in borderline ovarian tumor and non-epithelial ovarian tumor. In the stage 3 and stage 4, we can find it very high level, but only 50% of the cases of early stage disease, which is stage 1 and stage 2, we will have an increase in CA125. Important points about CA125. Don't sense for it if we have a simple ovarian cyst. If we have a high level, even up to 200, we have to exclude benign condition. Serial measurement is more helpful than one measurement, since rapidly increasing level goes with malignancy. A high level more than 200, we have to take an opinion of gynecological oncologist. And this picture shows the differential diagnosis of a condition with a raised CA125. Now, coming to the difference between risk of malignancy index 1 and 2, there is 2 main differences. Number 1, by ultrasound characters, in risk of malignancy index 1, they give it 3, while in risk of malignancy index 2, they will give 4 if we have 2 or more abnormalities. This is 1. 2, in postmenopausal status, they will give 3 points if she was postmenopausal in the risk of malignancy index 1, while they will give 4 points in the risk of malignancy index 2. Coming to the Royal College guidelines at 2003, they classify the women according to risk of malignancy index into low risk if the risk of malignancy index was less than 25, intermediate if it was between 25 and 250, and high risk if it was more than 250. But the Royal College guidelines at 2011 and even revised, they classify the women according to risk of malignancy index into high risk and low risk depending on 200 cutoff level. If it was less than 200, it is low, and if it was more than 200, it is high. And the specificities and sensitivities of this number is 78 and 87%. Important points: don't forget to sense a woman with a complex ovarian mass under the age of 40 years for lactic dehydrogenase, alpha fetoprotein, and HCG to exclude the possibilities of germ cell tumor. Don't routinely sense for CT and MRI for the assessments of an ovarian mass. Why? Because this will not improve the sensitivities or specificities obtained by transvaginal ultrasound. This picture shows the whip size calculators. We put the numbers and the calculator will give exact number rapidly. What are the pros and cons of risk of malignancy index? Pros: it is simple, reproducible, and most widely accepted, and still the Royal College guidelines using it. But the drawbacks of it is negatively affected, as we said, in postmenopausal women because of an increased rate of false positive and reduced specificities, and is primarily a marker for epithelial ovarian carcinoma. Coming to the case scenario. 52 years old menopausal woman presented with repeated attacks of persistent abdominal distension, feeling full and loss of appetite for the last 1 year. We sense for transabdominal ultrasounds and transvaginal ultrasounds. Transvaginal ultrasounds revealed a unilocular cyst with a mass occupying around half of it. By transabdominal ultrasound, we see a significant ascites. Why? Because its presence in the pouch of Douglas, exceeding to the fundus, and even presence anteriorly. Then, we sense for serum CA125, and the result was 95 international units per ml. Question 1. Calculate the risk of malignancy index. Questions 2. What is the place of your management? You will manage this woman in oncology departments, or you will manage her in gynecological departments. Waiting for your reply. Thank you.